Thank you. So welcome everyone to the Geriatric Medicine Town Hall, which is our new name, and you'll hear a little bit more about that later in the presentation today. We're so happy you could join us. My name is Susan Edgman Levitan, and I'm the director of the Stokel Center for Primary Care Innovation. I'm going to be the moderator today, and I'm also going to do a very brief presentation. So a few housekeeping rules before we get started. Everyone is muted so that we don't have any background noise that would interrupt our speakers. To view the speaker on your full screen, you should go up to the upper right-hand corner and you can click on speaker view, or you can also click on gallery view where you can see everyone. If your picture becomes jumpy or out of sync during the presentation, you can go to the lower left-hand corner to stop your video, and that often helps speed up your connection. We'll get to a point in the presentation today where we would love to get your questions. So please enter them in the chat function in the bottom ribbon across the bottom of the screen. And you just type them in, and I will be checking them throughout the presentation so that we can make sure to try to address as many as possible. I just want to remind everybody to please do not share or ask any personal medical questions, because if you do, you'll be sharing them with everyone in the on the Zoom call today. But if you do have a medical question, please reach out to your doctor directly. We'll do our best to answer all your questions, and if we don't have enough time, we'll try to get you answers after the call. So I'm very excited about today's presentation. We're going to be hearing from Dr. Sharon Levine, who is the Chief of Geriatric Medicine at Mass General. We're also going to be hearing from Dr. Matt Russell, who is the Director of the Geriatric Medicine Practice, and also the head of ambulatory geriatric medicine, and then a very short presentation from me. So with that, let's get going. And actually, while we're getting going, what we're going to be talking about today is a new program at Mass General called the Age-Friendly Health System that the Geriatric Medicine Division is leading. So just to give you a little background on sort of where this all came from. Back in 2012, which doesn't seem that long ago to me, I wrote a paper along with Dr. Michael Berry, who was the Chief of General Medicine at Mass General, and on shared decision-making, which is a method of how we try to involve patients as much as possible in making the right decisions for themselves when they're faced with a diagnostic question, with a treatment decision, or with a decision about screening. Similar to the topic that we talked about in our last town hall about how you make decisions about what screening test you want to have or you want to decline. So we wrote this paper, and in the paper, we argue that we need to change the clinical paradigm from just asking people about what is the matter with you, but to really focus on what matters to you. Because we know from research that when you really focus on what's important to someone, you can really help them achieve their overall goals for their health, and they also get much more engaged in managing their health more proactively. So let's go to the next slide. So we wrote this paper. Any of you who've ever written a paper or a book know you write it, it goes out somewhere, and you never know whether it's going to make a difference. And someone asked if we could please fix the sound. I think that's the sound on my end, and I apologize, and I'm trying to speak as loudly as possible. So what happened with this paper is that a friend of mine, a nurse named Maureen DiSignano, who at the time was the head of the Institute for Healthcare Improvement, which is a large quality improvement organization based in Boston, read the paper, on the plane on the way to their big European forum in Paris. And she decided to add it to her plenary session and to really suggest that people really begin to focus on asking people what matters to them. And this is what happens when you have an incredibly strong communicator and influencer. And when she did this, people from Norway loved this idea and began to implement it across the Norwegian healthcare system. It was actually led by their Minister of Health. So let's keep going. And this has taken hold around the world. So now let's go to the next slide. Now, the purpose of this is to really encourage our clinicians to ask their patients what matters, to listen, and then to do what matters in the course of their clinical care. The other thing that has happened with this is that we also are now using this with our staff. So it's very important to also understand what's important to the people who are providing care and providing all the other services that are delivered by healthcare organizations. And we found that it's equally important to them as it is to our patients. And it helps us take better care of the people providing care in the same way that it helps us take better care of our patients. So let's go to the next slide. I wanted to share this with you because it's just an example of how broadly this has taken hold. So it actually is being used. This is from a veterinary school in Scotland where they're using it actually with the students. But I always laugh when I think about what matters to you as a sheep. So let's go to the next slide. And I just want to end with showing you. So this is now something that is happening around the world. We have a What Matters to You Day that we are doing across our healthcare system. It's usually on June 9th. And because of this work, the Institute for Healthcare Improvement began the Age-Friendly Health System program with the Hartford Foundation because they felt it was critically important to focus on what matters to older people with their care. So with that, I'm going to turn this over to Dr. Levine, and she's going to share with you about the Age-Friendly Health System program and how we're doing that at Mass General.
Hi, everybody. I hope you can hear me. Can everyone hear me? If you can't, put it in the chat. So it's my pleasure to tell you about the Age-Friendly Health System initiative that we're introducing, and we've been introducing for a couple of years at Mass General Hospital. Just to put it in a context, the Age-Friendly Health System is an initiative of the John A. Hartford Foundation, which is a foundation in New York that's really, it devotes itself and its largesse to innovative programs for older adults, and especially in healthcare and in training for those who deliver healthcare. But it's a partnership between John A. Hartford Foundation and the Institute for Healthcare Improvement, which, as Susan mentioned, is a quality improvement organization that's based here in Boston. And this is in partnership with the American Hospital Association and the Catholic Hospital Association of America. And their aim was to get about 20% of health systems in the country to be age-friendly health systems. And currently now there are 2,359 health systems that are designated as age-friendly health systems. So I'll talk about how it relates to our activities here at MGH, but really the goal is to follow an essential set of principles that are evidence-based and proven in care of older adults. And remember, older adults were often left out of a lot of studies, and so there's not a lot of proof in areas, but we sure do have proof in other areas. So people who take Valium fall more often than people that don't, and drugs that are related to Valium. Things that don't cause harm. So drugs that can make you confused. And there are many drugs like that, including things like some non-steroidal anti-inflammatory agents, which can also make you bleed, which can also cause kidney failure in older adults. And then, as Susan so eloquently pointed out, what matters to the older adult and their family and caregivers. And the guiding principle is really important because what matters to you when you're 40, when you're 20, or you're 40, or you're 60 may not matter the same way to you when you're 89. If you're a diabetic and you're 50 years old, you may be really wanting to have very tight control of your blood sugar. When you're in your 80s, you want to make sure you don't have such tight control that you wind up in an emergency room because your blood sugar is too low, which is a very frequent occurrence and is one of the common causes that older adults wind up in emergency rooms. So what matters to you changes throughout your, through your life. And I think this is one of the important things is that older adults are allowed to take risks. There's the dignity of risk. I don't want to take that medication. I don't want to have my blood pressure that tightly controlled. What I want is to be able to play with my grandchildren, go and travel internationally as long as I can, stay as healthy as I can for as long as I can without losing the things that are important to me. And so the age-friendly health system and uh, we have is this the slide is up here now. I'm just going to make my own screen bigger so that I can actually see it. Hang on one second here. I'm just trying to increase the view here of my screen. Okay. It's based this it's a culture and a scaffolding. And so what matters is really important. And the other M's are medications. So is this a necessary medication? Does it interfere what matters with me? Does it make my mobility worse? Does it make me confused? Mentation has to do with your your memory and cognition and things like depression, which is very common in older adults, and delirium, which is confusion, often that occurs in any older adult, but especially in people who have memory impairment, and mobility, which is that making sure that people get to go where they need to go with whatever assistive devices they need and to do the things that they like to do. So when you're talking about mobility, you're talking about what matters. When you're talking about medication, you're talking about what matters. When you're talking about mentation, you're talking about what matters. And what I would say is that is really important, and I would love you all to ask questions about this as you're thinking about what I'm saying, especially around ideas like the dignity of risk in older adults, because a lot of people have helicopter kids who want to um, just want to, try and protect you from having things bad that might happen, but that might interfere with what matters to you. And doctors are also have to be told what matters to you so that they don't do things to you that you don't want done to you. The other thing is that when you are older, and right now, older adults are about 15% of the population, so people 65 and older, and soon will be 25% of the population. So you are outstripping kids. The pyramid of older people at the top and kids at the bottom is now becoming very square and will continue to do so. And that's why this is such important work, is that it's really important for this because you make transitions. You make a transition if you're coming into a hospital, whether you're going to an ambulatory clinic like our geriatric medicine clinic or the orthopedics clinic or a endocrinology clinic, you're coming from home. If you're in the clinic, you may be admitted or have something going on and you may have to go to an emergency room. When you're admitted to an emergency room, sometimes you go from there to the inpatient unit, and sometimes you go for surgery, which means you go to the operating room, and then that means that you go to post-op care, which means then you come back to a room afterwards. Every one of these transitions has to occur within this framework of medication, mobility, mentation, and what matters to you. And um, it's in these transitions that that stuff happens. Medications get forgotten, your glasses get lost, dentures get lost, medications get substituted, then you go home with 2 of the same kind of medication. So we're doing lots of projects here to try and address these issues. And if you want to put, well, I'll have you put in the next slide in a second, Monique, but uh, we are doing a project starting with the pharmacists. Our clinical pharmacists are working in the emergency room, and we're working very closely with other doctors who are non-geriatricians. We're working with the emergency room doctors, Maura Kennedy, who's the head of aging in the emergency room. We're working with Melissa Madison, who is actually a geriatrician and also is an internist and runs the inpatient internal medicine service, the hospitalist service. We are working with the clinical pharmacists, and we are working with nursing at the top level here. So one of the things that we are doing with the clinical pharmacists is when people come into the emergency room here, they're doing a study where they see all the medications that older adults are taking. And to make sure when they go to the inpatient unit, when they're admitted, if they're admitted, that their meds are known to everybody, and that if things are changed when they're in the hospital, that's noted on the way out the door. And so, but what we're including in that is they're asking about mobility at the same time as part of what they're asking when they're talking to people about their medications. So can they get up from a chair? Can they walk? Do they need assistive devices? We're asking about their mentation. So do they have memory impairment? Have they had confusion and episodes of confusion? Um, and we're asking about what matters to them by looking at their healthcare directives in the hospital and if they've been documented. And so this pharmacy project is really terrific. It's covering all 4 M's. I'll give you another example of something that we're doing. In the emergency room, there is a project being run by a nurse called Up by 10, so that even if you're in a bed in the emergency room, the equivalent of what 10 is, after a certain amount of time, you are gotten up, you are gotten out of bed, you are fed, you are engaged, you are talked to, and you're not just lying in that bed for an interminable amount of time. And if you have confusion, to do things that orient older adults in the hospital. It's been very hard during COVID because of the visiting in the hospital and in the emergency room. But that's a project we're doing. We're looking to see if it changes the outcomes. We're looking to see if the pharmacy project changes the medication accidents that can happen in the hospital and on discharge. Another project that we're doing is our serious illness conversation, which is talking to you wherever in many areas in the hospital. If you come into the geriatric medicine practice, which is now in Yawkey 2, and Matt will be talking about all the wonderful things that we're doing there. When you come in, one of the things that will happen is someone will say to you, what matters to you? I usually say, what matters to you most in the world? Most people say their kids, their family, all that kind of stuff. But a lot of people say that I can stay as independent as I can for as long as I can with the least hassle that I can. I want to be able to do some of the things I used to be able to do. So we ask what matters to you as part of our serious illness conversation, but we also ask, what are your hopes? What do you hope for? What are your worries? What do you worry about? What keeps you up at night? And then we ask people to think about if something should happen to you. Do you have a healthcare proxy? And have you talked to your healthcare proxy of what you would want in various situations? Because healthcare proxies really need to know. It's not about them. They have to represent you. So we're doing the serious illness conversation because it really is a way of documenting what matters to people if they get sick, but what matters for them. And that may change, right? If you have metastatic tumors and you are someone who's at a different point in your life, you may not want to have as much done as you would at another time. The important point is to have the conversation. That's the most important point. So I just put this together. I had my daughter try and help me put this together because it was hard for me to do this graphic. This really deals with some of the things that we're involved with in our practice. And we have our geriatric ambulatory programs, which include our consultation service and clinic. Matt Russell will talk about a lot of this. Our primary care practice, our co-management programs that we do actually on the inpatient service with geriatric orthopedics, the Continuum Project, which is about the serious illness conversation. We interface with our home-based palliative care program. We have a memory care initiative that is a co-management service around dementia with one of the internal medicine practices. And in every one of these places, we deal with what matters most. And the fifth M, which is there in the middle blue ring, which is multi-complexity. And there really are 5 M's. It's hard to assess multi-complexity because people have so many different kinds of problems. But multi-complexity means that mentation, mobility, and medication are all superimposed on all the many, many issues that people face. So that is, and we're doing that in every area that we work in the as we expand our presence on the inpatient service, the outpatient services, and in our own particular clinic setting. So Susan, I'm up to time here?
You're fine.
Oh, okay, fine. So I think it's really important to think about what we're doing. We love to hear from people about this, and it's important to know when you go to the hospital that people know what matters to you in terms of your medication. If you don't want to take 5 medications, if you don't want to have to take Lasix in the morning, you got to say, I don't want to take Lasix in the morning because I want to go out and go for a walk. And I don't want to take Lasix if I'm going to have to get at night because I'm going to have to get up 5 times at night. Can you do something else with that? I don't want to look like a person who is using a cane or a walker. Okay, let's get physical therapy to figure out how we're going to get you to get where you need to go. Some people like to use walking sticks like you use in the woods. Whatever it is, your dignity is important to you, and your dignity is important to the people that love you, and your dignity is very much important to us as well as your health care. It's your dignity and your choices, and the choices that you make for yourself. We'll tell you if we think that it's a risky choice, but that doesn't mean that you don't have the right to make some choices. So we have to work with everybody in the system. We have to work with nursing, PT, physical therapy, occupational therapy, pharmacy, all the physicians in every single specialty. And that's what we are doing. And we are reaching out. We're small but mighty. Many of you know that we don't have a gigantic clinic, but we do have lots of tentacles. We now have a clinic in the a heart failure clinic that we run through geriatrics in with cardiology. And Matt will talk about that. So we really want to engage you, and we want to engage the people that work with us to take the best care of you. And that's what an age-friendly health system does, and then proves that the interventions that we made a difference. If we look at your meds, that it makes a difference in giving you meds that can cause harm. If we deal with your mobility, we can prevent falls at home or in the hospital or anywhere else. If we help you get engaged and socialized, we may prevent depression. I know lots of you played online bridge during the pandemic. So even during this time, we can do that. So I want you to know that we're working with everybody because that's what geriatricians do. It's a team sport. It takes a village. And we're with you all the way through this time period and phase of your lives, which is so incredibly important to us. We're all going to be there, if we're lucky to live long enough. And so we value that, and we value you. So would love to answer questions when we get to that part about age-friendly health system, which is going to, people get recognition, and that means that we are, certified with the golden seal of approval. And we work through that by doing these projects and showing that we've made a difference. We increased the number of people who had serious illness conversations with us about what they wanted from 2% to 40% just by doing a few different things in our clinic. And we're going to get it up to 100% very soon. So I think I will turn this over to Matt Russell, who's the director of the clinical director of the geriatric medicine and clinical the clinic itself and all of our programs, our clinical programs. Matt, I'm going to turn it over to you now.
This is my newscaster. Wish I could. Thanks, Sharon. Is my sound okay? Can I get a thumbs up if the sound is okay? All right, I see enough thumbs up. So good afternoon, everybody. I'm thrilled. I see some good friends on the screen, and it's great to see you all. I'd like to start off first with some exciting news. So as many of you know, our prior geriatric medicine fellows transitioned out, and we have two new amazingly fantastic individuals joining us. They are Dr. Tolu Lope from Uyiro. Tolu, can you wave? Right there. Great, excellent. And Dr. Olivia Aronson. Olivia, feel free to wave. Excellent. So for those of you who had Dr. Degar or Dr. D'Souza with either Dr. Levine or me, you'll still have Dr. Levine or me, but these will be the doctors that you'll also be seeing. So just if you hear, well, I've never met that person before. We are an academic practice, as you know. We have trainees coming through every year. My personal preference as a patient is to have as many eyes on me as possible. Having these young, eager, amazingly brilliant people keeping an eye out for you is really what makes us feel thrilled to be educators. So with that, I also want to then move on and some other exciting news. If you have not already heard, we have moved. So we are no longer at Charles River Plaza on the 5th floor. We have moved down to the main hospital, and we are in the Yawkey building on the 2nd floor. So for us as the geriatrics team, we're very happy because all of the other specialists that a lot of our patients see in this building, it's one-stop shopping for them. So that's great. It's right off the escalator, easy to get to, good valet parking. So we're very happy with this location. And if our patients are hospitalized, it makes it that much easier for us to pop out of the clinic to go up and see them in the inpatient units. We also have a name change. So when you hear our front desk folks answering geriatrics or geriatric medicine, we are doing this to be in line with other the national what other national academic health centers are using for terminology. Senior health has been a name that we've used. It's sort of that the term senior has fallen out of favor, and geriatrics is what it is. It's sort of truth in advertising. So that's where we're at with the name. The last thing I want to talk about before we get on to the age-friendly stuff that we're doing in the clinic is to do a little COVID corner. I know that during the pandemic, we've had some conversations about COVID every month. And the hope is obviously that these topics are dying down, but I know a lot of people have questions about the Delta variant. Do I still need a mask? What's happening to all of these people getting COVID, even though they're vaccinated? Do I need a booster? So I would just direct you all, I'm going to put in the chat function, I'm going to put 3 different links. One is to the CDC, one is to the Massachusetts Department of Public Health, and the other is to our Mass General virus information. So feel free to take a peek at, let's see. Yes, okay, feel free to take a peek at any one of those if you have any questions. We are obviously dealing with a slightly newer, a new phase of this disease with the recent uptick in Delta variant and folks who are vaccinated having this, but they're not going to the hospital. and not dying as much. So we're happy that it says that vaccines are working, which we are thrilled about. Moving on, for those of you who've been involved with our practice for a long time, you know that we've mainly been primary care geriatrics. But it's become pretty clear that we need to change the way that we impact care of older adults, not just those that we take care of in our outpatient practice. And so while it would be great to have a geriatrician for every older adult, the numbers are not in our favor. So I think, as someone said in the chat function, you know, there are roughly 7,300 certified geriatricians in the United States, and they're not all practicing primary care. There's a need for about 30,000 geriatricians by the year 2030. So there are 44 million Medicare beneficiaries, and it's expected to rise to 79 million. So 7,300 for about 30% of 79 million might need a geriatrician. That's a significant number challenge. So we can't be everywhere that we need to be. And so that's where the term geriatricizing comes from. And that means teaching healthcare systems and also healthcare providers to provide geriatric informed care. So in addition to being physicians, we also operate in the boardroom level as advisors. And we also operate in the classroom as educators, not only for the students and residents and house staff, but also for colleagues who are well into their practice, but don't have necessarily a fully formed geriatric skill set because it wasn't really prioritized during their training. So how are we trying to geriatricize? It can't just be doctors. It's never going to be just doctors. If you have a geriatrician, you should also have a team of people with that geriatrician who are able to help manage the other parts of whatever may be challenging. Now, we have in the healthcare systems arena, we have representatives from nursing, from physical therapy, from pharmacy, and from other subspecialties who all agree we need to provide better care for older adults who have medical complexity. So what kinds of things are we doing? As Dr. Levine mentioned, our inpatient orthopedic colleagues have a partnership with us as geriatricians. So if an older adult has an unexpected fall with fracture and they get admitted to the hospital, they are not only being seen by an orthopedist, but they are also being seen by a geriatrician. The orthopedist manages the surgical complexity of that patient, and we as the geriatricians manage the medical issues that come up and also ensure that the patient is having a safe hospitalization with reduced risk of complications. As Dr. Levine mentioned, no one wants to lose those $1,500 hearing aids or those $600 glasses. But when a patient comes to the hospital with a fracture and a trauma, and they're having a lot of medicines and they're moving around, they can become confused. So something as simple as making sure that a patient can both hear and see is preventative for that acute confusional state called delirium, which is really scary because if you become delirious as a hospitalized patient, you can have a much more complicated hospital stay, number one, increased risk of needing to go to another healthcare institution after care, and also risk for sort of permanent cognitive injury and or death. So these are things that we as geriatricians are watching these patients like a hawk to make sure that that doesn't happen. But also what can happen is patients can have significant pain. And because pain meds are strong and there's an opioid crisis out there and people who fall and fracture may look frail, we don't want to give them strong medicines. And so they can have pain crises because all they're getting is a bag of ice and a Tylenol. So part of our job as geriatricians is to ensure that the pain is actually being assessed and treated at the level the patient's experiencing it. So this is one longstanding partnership that we have on the inpatient service. But we have no shortage of partners at Mass General who want to work with us to geriatricize their practices. This includes people from cardiology. So our advanced heart failure clinic has one of our geriatricians, Dr. Warren Backman, embedded in their practice. While the cardiologist is managing the complex heart issues and managing diuretics and strong blood pressure medicines, Dr. Backman is keeping an eye on making sure that the patient has the ability to manage these medicines, that there aren't medicines from other disease states interacting negatively. And again, recognizing things like frailty, polypharmacy, poly meaning too many, pharmacy meaning drugs, people who are on too many medications. We have Dr. Deborah Lee, who is one of our geriatricians embedded in the Chelsea primary care practice. She's there helping to geriatricize those other primary care doctors and be a resource to them for any advanced geriatric questions. I'm going to scroll down so I make sure I don't miss anyone. We have a partnership with oncology. For older adults who have a cancer diagnosis, we have a team conference with oncology to discuss patients as they are navigating their way through this difficult diagnosis and the treatments. And they are very brisk discussions. And I will say the partnerships that we are forming with oncology and the other divisions, it's like we're preaching to the choir. Geriatrics is not a hard sell. It is a very obvious and easy thing for a lot of other specialists to say, yes, let's get them on board. Some new programs that we're working on that you may hear about in the next couple of months. We are working with our surgery and anesthesia colleagues around a perioperative optimization of senior health patients, or POSH. And what that is if you're going for a complex surgery, the surgeon will send you to the geriatrician to assess you for things that we can optimize before you go to surgery and put traffic cones and police tape around anything we might think you could have in the hospital so that we have a plan in place should that complication occur. This has been done at Duke University, and we are replicating their program up here. So the expectation is that's going to go live, at least the outpatient portion, in the next couple of months. We're very excited about that. As a hospital system, Mass General is trying to apply for the geriatric surgery verification, meaning that we are aware of the needs, the unique needs of the older adult population around surgery, that how much anesthesia they get, what kind of anesthesia they get, how quickly they're mobilized after surgery, how their decisions are taken into account about what their wishes and wants are about their aftercare. All of that will be part of the geriatric surgery verification program. Finally, as I'm sure many of you know, dementia or memory disorders are a very common illness in advanced age. And Mass General has a very large number of clinical resources and support resources around this. But sometimes one hand doesn't know what the other is doing. And that's what happens when you have a huge 1,000-bed hospital with multiple offices and stuff like that. So what we're trying to do is actually coordinate a memory access hub. And that's going to be working with neurology, geriatric psychiatry, geriatrics, and our dementia caregiver support program. So stay tuned for that, because we really are hoping to have a one portal of entry for anyone who has a question about this, for not only our other providers, but also for our patients. So those are the big programs that we're working on. We'd love to hire about 20 more geriatricians and geriatric nurse practitioners, but we're as rare as hen's teeth. So if you can catch one, grab it, and I won't ask any questions. Get them in here. Thank you very much, and feel free now if anyone has any questions, or I'll hand it back to Susan.
Thank you, Dr. Russell. Can people hear me well enough? Okay. So a couple of questions. I want to, I'd like, and I think this may be for Dr. Levine, but there are questions and comments about the pipeline in geriatrics and how we're trying to recruit people. Do we need to open up more residency slots? You know, can you share a little bit of what's happening on that front?
Yes, I can. I've been very involved in education, geriatrics education at the national level for over 25 years. And there is a pipeline issue. We have gotten geriatrics into medical school curricula. There used to be 0, but there are some schools that have it for a month. Harvard Medical School is increasing, I think, up to 30 hours in their geriatrics and palliative care thread, but they really need that clinical time, which is hard to get. That's just sort of in the training area. Most medical schools are adding time. There are now combined geriatric internal medicine residency programs. So you can apply to a residency, and in 4 years, 3 years is a normal internal medicine residency. Now in 4 years, you can get geriatric medicine and internal medicine combined and interwoven through those 4 years. You know, Matt introduced you to our 2 new fellows. They are as rare as hen's teeth, but we work very, very hard. Esteban Franco Garcia, who also runs our inpatient orthopedics program, is the fellowship program director here. And one of the things that we try and do is train our fellows in many different locations. So they're outpatient in clinics, they're in nursing homes, they are in primary care practices, they are on the inpatient service, they're doing palliative care, because we know that they will get snarfed up no matter where they go and what they do. One of the things that is really rare as hen's teeth is people who are doing research in geriatrics. And so we're trying to do that also. But it is the schools that are spending a lot of time on geriatrics. Where I was before I came here, students had 1 month about patient geriatrics, and a lot of those, and there were several months on the inpatient unit too. And a lot of those people wind up going into geriatrics because a lot of people don't know what it is. And then they go and they do it and they become converts. So I think that the question is a really important one because people don't know what they don't know. I didn't know anything about geriatrics. My grandparents were really young and the other ones were not alive. And it wasn't until I did my residency program at Yale New Haven Hospital, where there was very robust geriatrics, that I fell in love with it. And I can tell you about Dr. Russell, who came on to geriatrics as a resident and said, "Oh my goodness, this is where I belong." And so people have to get exposed in order to want to do it. It's not for lack of training sites. It's for lack of people who don't know what a fabulous life and what a fabulous addition this makes to other people's lives and to the institutions that we work in the village that we create. So anybody that you know who has any inkling, I'll talk to anybody, anytime, anywhere, because it's so important to increase this pipeline. So thank you for that question. We're working hard at it. I was just online with our student mentorship group, our student interest group the other night at 8:30, and they are doing advocacy work. They're writing papers. They're doing all kinds of stuff. So all you need is a few, and we go forth and multiply the best we can.
Great, thank you. So Dr. Russell, a question for you, and I think this is a really important question, is about how is the work with the age-friendly health system and the geriatricization of care, coordinating care with local pharmacists? where people get their medications refilled and all of the issues around that, which I know you're well aware of.
Right. So some of this, it depends if it's around a transition. Oh,
Matt, I'm sorry, this is Judy. Excuse me one sec. Do me a favor and everybody a favor and repeat the question when Susan says it.
okay. So the question is, how are we collaborating with pharmacy, either in a person's neighborhood pharmacy, or I assume inpatient pharmacy, to ensure safe transitions of care and making sure that a patient is on the right drug for the right disease. So as a standard part of the geriatrics encounter, we do full medication review. And what we try to do is ensure that whatever we have in the computer accurately reflects what you are actually taking. Because when a patient is in the hospital, medications can accumulate like dust bunnies. Well, we wanted to put them on an aspirin because we thought they needed that. We wanted to put them on something for their stomach because we didn't want them to have an ulcer. We gave them 10 different vitamins, and then you come home and you've got 26 vitamins and you're not really sure what they are or if you need them. So that is the part of the geriatrician skill set, to actually review your medicines and, in a post-hospital follow-up, say, okay, this is what they did to you in the hospital. What's your understanding? Dr. Levine and I like to see the actual medications. Bring the brown bag in so that we can look and see that you're not taking two medications that one might be the brand name and one might be generic, but they're actually the same medicine. We also are frequently in touch with local pharmacies around this, and they are in touch with us to make sure that if there are any red flag medications, we hear about it. In geriatrics, we have, polypharmacy is a name for too many medicines, but what really polypharmacy means is inappropriate drug prescribing. There is not really a reason for this patient to be on this medicine, or this patient is on too many medicines that interact with one another, or medicines that interact with their disease states, or inappropriate dosing of the medicine, because as we get older, the metabolism of some of these medications might slow down. So all of these considerations operate under this M. In our emergency room, pharmacists are reviewing a patient's medication list and updating it. So they're walking over to the patient in the emergency room and saying, can I go over your medicine list? Which pharmacy do you use? Let's go and reconcile. That's what we do. We call it medication reconciliation, to make sure that what you think you're taking is what we think you're taking. And if there's any need to negotiate, we're having a very clear discussion about what our expectations are for one another. So many times people go to an expert, they get another pill added, they nod, they don't take it. Then they get another one, they nod, they don't take it. They come to see us and we see there's so many medicines, and we find out which ones you're actually taking. We don't want them just to say, I'm taking all of my medicines. We want the truth, because the last thing you want to do is end up in the hospital with this big laundry list of medicines that you're not taking, and some brand new doctor says, let's give them all to them. So I hope that answers some of the question anyway.
I have another question about, can you say more about what people can expect when they're in the hospital, and whether they will get a visit from one of our geriatricians at every hospitalization or only certain types of hospitalizations? I think that's what the question is asking.
It is. So that's phenomenal. So I think at the get-go, I would love to say we'll be there for you every time and we'll be able to get up there. The reality of the situation is that if I'm in a busy clinic, I can't break away because I'm seeing other patients, or if I'm just drawn in a million different directions. That being said, we have, and we do, cyber stalk you. So if we know you're in the hospital, we're following all along. We have twice a week case conferences in geriatrics where we talk about our complicated patients, our hospitalized patients, any concerns that we have. Certainly, if I see a patient that is having a complicated hospital stay where my input needs to happen, oh yes, they will get a call, and I would hope I'd be able to get up and visit. But as you can imagine, depending on where the doctor is, it's hard to promise that. So we'll see what, I guess the dad answer is we'll see, because we have to know what it's like. We're only a week into the new space. And so I haven't been able to really check with the other doctors and see how they're finding it. I've been able to pop down to the emergency room to see my patients. And that's been good. I can keep an eye on them. I happen to be on the orthopedic surgery service now, so I'm in the hospital, so I should be able to see my patients.
The other thing is, I guess I would say is, many of you know, we talk to the people who are taking care of you in the hospital often. We will actually call up the doctor or the house staff or the nurse on the floor if we, and this was really true when we were over at 165 Cambridge Street, because it's so hard to get away from the patient care that we have. But Matt is right. We're reading your charts. We're on there. We know what's going on. Sometimes we call your significant others because we know it's hard to get you in the hospital. And if in my ideal world, if we could have a consult service or co-management service for our patients, that are all of our patients that are in the hospital, that would be the ideal thing. But it's very, 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 very hard to do that with a small group like we have. But we really try, and all of us care, and the nurse practitioners do too. The nurse practitioners are involved in talking to nurses on the floor, and there's a lot of communication on the way in to the emergency room and up to the floor. And there's a lot of communication that comes on the way out that you probably don't hear about unless you write to us, but that we're doing every day of the week. I want to say one other thing. I want to answer a question because I was looking at the chat, because the person who wrote the question about training asked about, there's so many reasons why people don't go into geriatrics. They don't get paid. There's not enough place in schools, etc. And it is mandated a little bit more. It's not mandated the way some things are mandated, but as someone who finished paying back her loans at the age of 49, you're right. The people that go into geriatrics go into it because they love it, and not because they're going in it to get rich. But let's be honest, doctors, are doctors. We make choices too, and we as long as we can repay our loans, we're good. And you're right, the reimbursement, which is something that we fight for. I'm on the board of directors of the American Geriatric Society. We lobby in Congress for the reimbursement for the care that we deliver in the office, in the hospital, in the community. And we lobby to get reimbursed for what we do, because what we do is a lot, and our appointments are most of you don't have a 10 or 20-minute appointment with us. We spend a lot of time. So we do lobby, and we work with people in Congress to try and make these points.
So
Thank you so much. I don't see other questions in the chat at this moment.
It looks like there's one.
Oh, let's see, from Sunny.
No, go down.
Hold on. How
I
does
can see
one
it.
become one of your patients, either full-time or on a consultation level?
Yes. So
Dr.
if you would like to be seen in our clinic right now, our primary care clinic, because we are expanding some of our other models to help other practices. We're not really accepting new patients at this point for primary care, but we are wide open for consultative visit. And what a consultative visit is, your primary care doctor or you calls our practice or makes a referral to our practice for a geriatrics consultation. Usually we ask sort of what is the reason for it? Because we've had, triathletes who are 65 say, well, I'm 65, so I need a geriatrician. And you don't need a geriatrician. You need a geriatrician, for a little bit more advanced. If you're playing golf three times a week, you probably don't need a geriatrician. You need to tell that geriatrician what you're doing right, so that we can advise our patients. But for those who have concerns like, I'm seeing so many specialists and I'm really having trouble understanding who's steering the ship. I'm having a lot of time with all the medicines that I'm on, and I want someone to do a review. Or a lot of times, I'm feeling like my memory isn't good and I've gotten some feedback from friends and family, and I'm hoping that someone can take a peek at me. Or I've just, I can't do for myself the way that I used to do, and I'm wondering if there's anything I can learn or do to see if I can regain some function. And many times we do have a lot to offer in that realm. Sharon, did I leave anything out?
No, but I want to answer the question about having a satellite clinic in Portsmouth, New
good.
Hampshire by the
Yes.
beach. We would love to.
Yes.
As we said about the rarity of it, maybe Olivia or Tolu want to live on the beach. Maine is pretty bad too.
Yeah.
We know that, and it's really hard for people to schlep down here, nor
Mhm.
should they. They need primary care. That's one of the reasons why Deb Lee has got this clinic in Chelsea. And if we can build, the reason I came here was to build this, and one of the first things I did was bring Matt here to help me do that. Dr. Russell, is we will do it if we can recruit more people and let people know. If you let people know, this may make a difference. So
Thank
And
you.
I vote for, in addition, Scottsdale would be lovely. About February to March, into April a little bit. I'm happy to be the geriatrician, the traveling geriatrician. So a lot of the other stuff too is, because as Dr. Levine says, our product is time. We are taking the time to take the deep dives that your other providers would love to have, but because they're also in short supply and are doing so many things, we're doing that. Well, time doesn't make money. It saves money. It gives good quality of care. It gives good quality of hospitalization and gets people out of the hospital sooner. But it's hard to make that financial case. And that's one of the reasons why geriatricians are hard to recruit. We just don't have the funding for them. But our hope is that by doing these demonstration projects, we'll justify that to the folks who actually do have the ability to allocate resources to us.
I want to thank you all so much for being part of this very dynamic and interesting conversation today. And Dr. Levine and Dr. Russell and Susan Edgman-Levitan, thank you so much for your information on age-friendly and on geriatricizing Mass General Hospital and our lives. And we are taking a break from doing the town halls in August. So we hope that you all stay healthy and have a wonderful, warm, sunny August. And we will be back with the town halls. If you have any specific items that you want us to have town halls about starting in the fall, please email any of us, your doctor, Susan, Monique, myself, and we are very available to you and really looking for content so that these town halls are what you want to hear. Susan, was there one last thing that I should be announcing? Okay, great. Thank you all so much for joining us, and we will see you in September, as they say.